So what I'd like to do is give you a brief overview of what program size means in the public health context. Now, I hope you'll find that this presentation, with its different elements, really resonates with the three previous presentations. I'd like to pick up the challenge that Jamie left us with, but program science in the global north. What do we do nationally? In fact, some deference to the World Bank as well, with its interest in developing countries. I think we could probably say that we have some certain similarities in certain populations, especially our indigenous peoples, that are not so different from the developing world. And finally, Sevgi, with your comments about science-based and systems approaches, hopefully that'll resonate. So, do need to say that, and it's contextually important for program science, that public health in Canada is a shared responsibility. Canada is a federated nation. Public Health Agency of Canada by no means does everything. It does try to provide some sort of national leadership in surveillance and guidance. As you can read here, I'm not going to read through, I'm trying to save us all a little bit of time here. But it is really that overall broad concept of what does public health mean to the nation. Specific programs that we have, though, for capacity building and emergency preparedness that is almost unique to the agency. But we interact and need to interact very closely with the provincial and territorial counterparts, with municipal health organizations, and with the communities and civil societies themselves. They're all part of the public health system and go right down to the elements of delivery, of monitoring, of, in fact, providing that essential linkage to testing effectiveness of various interventions. So that is the broader context. Now, the agency, Public Health Agency, is 10 years old, roughly. We were structured in order to respond better to public health emergencies such as SARS. There's been a tremendous evolution in the agency itself, taking on the mantle of public health as a systems approach for Canada altogether. And we have now come out with a formalized statement of strategic directions, which, when you read them all, are pretty large, pretty almost, I won't say grandiose because they are real, but they're large. And they cannot be implemented without a somewhat structured, I would like to say even rigorous approach that is premeditated and ultimately, when you dissect it down, means a program science type of approach in order to accomplish and meet all these various directions and priorities that are there. So, more specific to the STI side though, dissecting this out a little bit, we have some significant challenges happening in Canada. The rates of STIs or STBBIs, bloodborne infections, are not decreasing. They're increasing in some cases, in fact. You can't make a blanket statement. Chlamydia is increasing, syphilis is increasing. Concurrently, certain antimicrobial resistant or otherwise drug-resistant infections are also increasing. A new one seems to come up for Canada about once a year. And we, for instance, can focus on AMR gonorrhea as being one of those cases in point. Overlying all that is something we have no control over, and that is that people mobility is happening, is there in our world. Canada is expecting to have a 39%, if you like, foreign-born population in the course of the next decade. That is mobility, no doubt. And the reality of that is that global travel times is less than the incubation time for pathogens that have outbreak potential, epidemic potential, or even pandemic potential. So the risk factors are really increasing as to how you deal with that. The increased interconnectedness between infectious and non-communicable diseases is definitely there. We see that there are interlinkages between HIV and chronic comorbidities. Mental health is being integrated more and more into what we do in STIs. And as I said, there are certain populations definitely at risk in Canada whose societal needs are not being met. General populations, certainly the societal needs are being addressed, and for most Canadians, they don't have those same issues. But there are inequalities, in particular amongst Aboriginal people and various ethnocultural minorities and migrants. Well, actually, I'll go back for a second. There's the whole aspects of aging demographic. That is a specific population, while not small, clearly, is drawing additional attention where we do need to have public health actions and interventions that need to be more tailored to the issues that are arising. We know already it doesn't increase the prevalence of non-communicable disease, their age-related disabilities, and there's definitely a higher risk of injuries and infectious disease sequelae. So, public health. Public health agency sees itself as a science-based department, a research-based, science-based department that does its work on that. So maybe it's not unusual to think about think about program science as being really a deliberate application of a scientific method, just by analogy. I mean, a scientific method, for those of you who are research scientists and gone through a traditional school, you know that it starts with observation and it ends up with conclusions through defined, restricted steps along the way, where each of the steps has to be met according to rigorous principles. And then there are feedback loops that happen once you reach a particular conclusion, where you say test, that could be an intervention. And those feedback loops, importantly, allow you to try again with a modification for a new or different outcome. So here, when we apply the program science elements, which in the context of what Jamie and Sevgi and David have been talking about, really goes from design of a program to implementation of that program with its interventions and ultimately the evaluation of that program. The significant activities really of the public health domain in Canada, from surveillance all the way down to health promotion, all of that can be made to fit into a program science context. It cannot all be done by the Public Health Agency of Canada. It can't even all be done by the public health bodies within Canada. It requires other sectors. It certainly requires the civil societies and communities. It requires industry and others to be part of that structure. And I think that's where our future challenge is how to do that in a national context, but also in an international context. So, do we see value in that? Yeah, clearly. I think we've already indicated it. More effective risk-based planning of the programs themselves, with a higher probability of success, with a lower cost, et cetera. The effectiveness of the implementation itself and efficiency thereof is what we're going towards. And an element that if you have a rigorous plan in how you're going to implement a program with a defined outcome, it allows you to assess that program. And that assessment is increasingly so, in governmental bodies at least, related to accountability. And the accountability is for supporting funding decisions, the current as well as future funding decisions. And in the federal government also meets very formal requirements of program audits, program evaluations, and you can put capitals around audits and evaluations. They really are a very formalized process. And even nowadays, so-called performance management, which is a new jargon, but that is placed on government programs and government executives, by the way, where you really have to account for what you said you would do. Well, you'd want to do that in a fashion that lets you roll back the clock and say, I did this because. In other words, a deliberate, premeditated way for going from the planning phase to what you're going to be implementing, and what the interventions are, and that you get the result. And if you didn't get the result you expected, be able to interpret that in a fashion that says, this is why. So, as I said, none of this can be done as an individual organization, but is multi-sectoral, multinational, multidisciplinary. Give you some example. Well, I'll give you one example in a little bit of detail. There are multiple examples within the public health system in Canada, not just the agency, where program science is being practiced in part. I don't think I couldn't find a single, or my folks couldn't find a single example that said, right from the very beginning of implementation to the full evaluation process, that program science, there was no example that met all that. But there are many different examples where we have dealt with 2 or 3 of the elements, interlinked elements that we say are part of program science. And you hear some little bit more of that in the panel discussion coming up. So I just said multiple examples. Give you one example in specifics. In Saskatchewan, the HIV control program, case in point here. The observations phase of that said surveillance data was available, came from the Saskatchewan health centers. Okay. Data was analyzed with the agency's assistance here, and definitely identified increased incidence of HIV amongst Aboriginal peoples. The actions that were taken, you can see them there. To understand geographic differences, collaborations were essential. Data analysis was essential. Capacity building specific to the Aboriginal target population was done. CIHR has been in there to define that type of capacity building that would be required through their Best Brains exercise. There's a beautiful program that CIHR runs, which is the Best Brains approach, which basically brings small think tank, tightly focused exercise. And again, making the point that the civil society was actively engaged in the planning and implementation of that program. So with an outcome that we have increased capacity for surveillance and epidemiology going forward, increased outreach, testing, case identification, and the linkage to downstream and the ground care. And actually it supported the justification of interjurisdictional, intersectoral collaboration, a good thing. So if we look forward, how are we going to implement program science better or even more in Canada? Well, there's a caveat. I think the understanding of what program science means as a concept is disparate. It's not clear amongst all the practitioners that have done some of these elements of program science. And there's some question about the benefits. I think we still have some proselytizing to do here in Canada. Certainly within the agency, I think we intend to be a proponent of that. We want to see an increased use of program science in the design and the implementation and evaluation of public health programs. And we see it as the following, as the whole list of potential areas for collaboration, where they're aligned with that national mandate that I said the agency has. All of these different elements, right from national surveillance and epidemiology and why you might want to do that, to the strategic engagement and investment by stakeholders, all of those elements can be couched, can be expressed with a program or through a program science lens. So this is really where hopefully we'll get to in the discussion on the panel. You know, your reaction to that application of that the program science concept in the national context of Canada, and where are there opportunities for more collaboration than we have already, and it's broad. So with that, I'll close. Thank you.